Good morning and welcome to our monthly live broadcast for endovascular cases here from Mount Sinai Hospital in New York City from the Department of Interventional Cardiology and Endovascular Services. I'm your moderator for the day, Vishal Kapoor, and I'm joined with my partner, Dr. David Song. Welcome, David.
Thank you.
So we are here for another exciting case, some learning cases from Dr. Krishnan and the team down into the lab. So before we hand off to the mic to Dr. Krishnan, I just wanted to let you know about our annual NYEVS, New York Endovascular Summit, which is scheduled this year, September 11th through the 13th. Great, exciting 2 days of hardcore academic brainstorming with world-renowned faculties arriving onto the podium to have a very good interactive session, more learning from the endovascular perspective, to have a multidisciplinary approach involving vascular surgery, interventional radiology, podiatrists, interventional cardiologists, and other general cardiologists always in the field, all coming together to New York, enjoy the weather, and have some academic brainstorm. Our details are available on the website, nyevs.org. Also for the fellows, as ever, we have our famous endovascular fellows course, which is a dedicated full course involving Mount Sinai faculty giving experiences and having some academic didactic sessions for them for the entire day, attended by more than 80 fellows every year. So we're hoping to see the same bunch of amount of people coming this year as well. So without further ado, good morning, PK.
David, good morning to everybody at home. I'd like to welcome you to our program here. Again, this is the penultimate program for this year, this calendar year, this academic calendar year, with our fellows, Dr. Doshi and Dr. Money. I'd like to, welcome our team here at Mount Sinai. To my right, we have Dr. Karthik Guja, who's the Director of Endovascular Services at Mount Sinai South Nassau. Behind me, we have Ray Lascano, who's our endovascular nurse practitioner, who's been with us for every single case. And we have an excellent nursing team today. We have Denise here, and we have Reka. And then we have Damien, who's back from vacation and ready to run around and help us get this done. Of course, our wonderful AV team. And, I'd like to, reiterate what Dr. Kapoor said and welcome all of you to NYEVS, and the Fellows Course. Dr. Guja and Dr. Sharma put together an incredible program for the Fellows Course with a who's who of faculty for both the vascular surgery, IR, and IC side. And of course, Dr. Kapoor has been instrumental in putting together the faculty and the program for NYEVS. So we hope to see you there. So we have a very interesting case today that was Dr. Guja's patient. So I'm going to allow him to present because I think he knows the patient best. But again, I think the idea here is a conceptual change in how we're treating below-knee disease with the advent of newer technologies and things that are on the horizon. So because I think this case really illustrates what's happening in the field of endovascular in terms of maybe how we're going to start to use the available data and the technology to really increase our outcomes. So without further ado, Dr. Guja.
Good morning, everyone. We can go to the next slide. So we have a 74-year-old male patient with a history of severe resting pain on both sides for quite a while, and has now developed progressed over to a fifth toe wound on the left side. Patient is a high-risk patient with prior left main intervention, bifurcation interventions, so not a candidate for surgery or anything, with prior multiple MIs and cardiomyopathy. Patient is on all the medications as suggested, aspirin, Brilinta, as you see, because it's a left main bifurcation intervention. Coreg and Entresto. The EF has improved significantly over to 45, but still patient stands to be a very high-risk patient. Next. Patient, as discussed now, has progressed over to a toe wound on the left side with diminished pulses on the DP on the left side. The ABI done prior to 3 months ago, prior to patient developing a wound when he was having resting pain, was 0.34 on the left, and the arterial Doppler shows significant intrapopliteal disease. Patient has been managed on medical therapy as of now, but now, as we said, progressed over to the left toe wound. So Wi-Fi classification is 101, Wagner is class 1. Of course, in a Rutherford class, it becomes 3 and 5. So next picture.
So I just wanted to, so Karthik, you know more about this patient, and I want to show us the angiogram. So what had happened, guys, is that the guy, he has a right common femoral artery stent with a supera. And maybe Karthik, you can talk a little bit about
so
why.
patient had a wound about 1.5 years ago on the right side, grade 2 wound. Patient had right common femoral about 90%. Patient had a left main intervention 4 months ago, bifurcation intervention, for which we could not stop the Brilinta because patient had a prior MI in Philippines and came over here, and the EF was 20%. So left main was totally occluded with, and patient was not a candidate for bypass because LAD was not reconstituting. So we had to reconstitute the whole coronaries. So it's a high risk intervention. So we had to end up doing a supera because patient had gangrene on the right grade 2. This was a year and a half ago.
Yep.
And it was discussed with the vascular surgery team here, and I think we did a whole team talk.
Yeah, and as everybody knows, that there's some data coming out with supera, with the VMI CFA study that's ongoing, as well as the TICO trial and other different trials. We've obviously, you can refer back to our library. We've done common femoral artery in detail here. And you know, the beauty of the supera stent, Vishal and David, and as you know, is that you're able to put a 4 French sheet through it without a problem. You know, you may say how we're going to close it. Our plan is to close it with Vascade. And the reason we did it is honestly, we could have gone just Antegrade the other way, but I think a live case, just to have good control, just God forbid if anything happens, to have access is always a smart thing. And I think having done a lot of live cases, always prepare for things that may happen. So we just have a small 4 French sheet through here, which we're going to use a Vascade to close, which should not be an issue. So I just want to go next. I mean, as Dr. Guja knows the patient well, you can see here, let me control it, I'll show you.
Go for it.
So you can see here that now this is the shot of the left SFA Karthik. As you see, common femoral is fine, but I'll show you a better picture. Yeah. You can see here no occlusions. And then as you guys can see here, as you come down, he has a pop stent too, Karthik, right?
Yeah, he has a proximal pop stent. This is from 4 years ago in 2022 or 2021. It's still patent. As discussed on the arterial Doppler, which coincides with what we have, the patient has significant intrapopliteal disease with occluded, again, I think we skipped, occluded anterior tibial.
I think it comes back to it. Yeah, there it is.
Yeah, right there. Occluded anterior tibial.
Right there.
And the peroneal has about 99% lesion, and posterior tibial is occluded too. The posterior tibial does not form in the foot, but the dorsalis pedis forms in the foot via the, I think, multiple collateralization. I don't think collaterals basically come from the peroneal, but they come from some kind of a pseudolaterative collaterals.
Go next. You'll see a good foot shot. So again, as you know, it's always good to take good foot shots, and we took a nice lateral shot of the foot. This is just show you the occlusion of the AT, and here's the foot shot. And you'll see that you have a good foot shot that clearly shows that the anterior tibial artery forms, and then you can see that the anterior tibial artery will well, I didn't show you the arch, I'll take you a better picture now, which will then show that you have a little constitution of the posterior tibial, which we may go after. We'll talk a little bit about it. So I just want to take a better foot shot here, just to show the arch, which I think is important anytime we do a infrapopliteal lesion. Let me see here, a little AP.
Beautiful. Just to let you know, we've been joined by Dr. Raman Sharma, who just is here, right here.
How are you?
An upgraded version.
Hey, guys.
Yes. So, good morning, Raman.
Morning.
Dame, can we pull him up a little bit, Dame? It's, you know, this table is really giving us a lot. There you go.
So I think, yeah, Raman, it's a very good point that PK brings up is, you know, how we underestimate taking the foot arch anatomy, defining pre-intervention because of the sequelae, especially in these patients where we are so much dependent on collaterals and multiple branches, and how by aggressive intervention we can lose these branches and not essentially help the patient, even though they might collateralize well from other vessels. So I think it's a good point to come up to say, hey, we need very good pictures of the foot and not only look at my origin of or the CTO segment of the vessel we're trying to treat, but the origin, proximal and the distal caps, I guess.
Yeah, I mean, Karthik also pointed, you know, he hinted at this us one idea about whether or not the vessel reconstitutes in the foot.
Ready.
And I think take that into consideration really does identify which targets you're really going to be trying to revascularize percutaneously, but then also at the same time, as you mentioned, be really wary about sacrificing really important collaterals to try to make inline flow, even if it's through actual through collateralization.
Correct. And I think it's always obviously have a good idea to see worst case scenario down the lane. If it fails, the intervention, they know exactly where the target is, how the distal targets are for possible bypass, if it might be considered in the future. So always good to know. So you can see, wow.
So
there's a lot of disease proximally, so it's hard sometimes to visualize.
A touch of the DP there.
Correct.
An even smaller touch of the PT.
Jesus Christ.
Well, let's move the leg inside now.
Yeah.
Ready? Inject. So I just want to show you. So it's a angiosome. It's a dorsalis pedis ulcer. So and we can talk a little bit about revascularization and angiosome versus non-angiosome, direct versus indirect. So you can see here there's good flow, and then you can see the posterior tibial start to come back slowly. It probably is just hibernating there, but you can see here that we probably have enough blood supply to do it. So we've got antegrade access, as I showed you, and what we did here, for those at home who don't like antegrade access, is we just put a 6 French sheet down, and I just want to show you a little trick that a lot of you may do, may not do, some people do, some people don't do, to avoid radiation, is you just put a 6 French sheet down, and then you just loop the catheter across and make it like an up and over sheath. I don't know if you guys can show the camera, please. AV team, can you show the sheath, please?
On the groin side, yeah.
Right here, guys.
I think the II is actually in the way.
Watch yourself, PK. Yeah, try it now.
So you tape it in a way as if it's up and over. Interesting.
That's cute.
So we moved everything up and over. So now you're up and over here. So you are obviously. Can you center the camera, please? Show me the groin.
We see it.
Yeah, we see it. Yeah.
So the idea here is now that it goes antegrade down, and then you're up and over to avoid the what is it called, a lot of radiation. So now we're going to bring this camera back. So now the idea is, can you go to the ostium, Karthik, show the occlusion? So I guess the idea is wire choice and how you guys want to cross it. We're prepared for obviously antegrade, a retrograde approach as well. So the idea would be is, what do you guys think looking at the lesion in terms of the wire? I know I made my wire choice already, but I'll show you guys the ostium.
We can take a picture.
And we could talk a little bit about wire escalation. Here's the antegrade stick, and then here's the wire, here's the sheath. And let me see the picture here.
Want me to do it?
I didn't see, Raman, did you see much calcification? I mean, there is a CTO, but let's look at some pictures to see if it's how densely calcified it is. Because that might also...
It's moderate calcification.
Yeah, a little bit in the proximal segment.
Okay, yeah, just want to see the cap.
So this is the reconstitution.
That is also a good point to determine, yeah.
So you could see the collateral that Karthik and Raman were talking about from the posterior tibial. I don't even think that's the posterior tibial.
Yeah, I think it's a sural collateral.
It's a collateral. And then here is the perineal has a lesion as well. There it is. Now this is the ostial shot. So you have a collateral coming off. You have a tight perineal. So you have basically no direct flow to the foot.
Yeah.
So what wires do you think you guys would do?
All right, good. All right, Raman.
I mean, I'm pretty quick to escalate to, I think the Confianza is typically my first choice. I like to have a nice microcatheter across, because sometimes when you see a little bit of a channel, I think, if you are really diligent about the imaging you can decide whether or not this is actually a collateral making its way all the way down or the true vessel. I think in this particular case, it looks like there's about 10 centimeters of what looks like a vessel, but I think it's just a bridging collateral.
Yeah.
And then you can kind of get, if you start to do a lot of work down that path, then you can really cause a little bit of trouble, especially when you start to do the ballooning, so on and so forth.
I mean, again, it depends. I mean, it's all the anatomy driven, the C-top, how way the cap looks. I mean, if you think,
You take
which
another
I'm a
quick-
believer,
actually, no
is
bother.
there's always some hibernating vessel which is present. So I usually try to start with a support catheter and a hydrophilic wire with a little support to see if there is any way I can get down into some hibernating vessel. If it's totally flush, blunt occluded, hard calcification, you're right. You go with your
You
weighted
put me on
wire,
coronary.
non-hydrophilic, and just try to break the cap.
Yeah.
But if it's anything that is suggestive of some hibernating vessel, I usually start a little bit low, meaning like a hydrophilic wire. Try to find a little bit of channel till the time you get to the real CTO, and that's where you need that
wanna show
pushability.
the
And then you,
calcium.
like you said, rapidly switch over to your
Yeah.
more weighted wires and try to cross the CTO lesion as well. So won't be wrong with starting a hydrophilic wire in this case with a support catheter to see if you have some microchannel, and then go down and then exchange and upgrade your wires as needed.
Yeah,
What's in your
so-
mind, PK? I know you've already decided.
Well, that's what Karthik and I talked about. I think we just we have the hydrophilic,
Teleport.
we have the teleport ready, but we're just going to try with the wire. I agree with you. I think this is mostly hibernating, so I think it's going to cross quite easily. There's the cap that Raman was talking about. Let's see if it just kind of pops through
Right on the bone.
and right on the bone there. So if not, there it goes. So it's already crossed. So I think Raman, I think you're right. There was a hard cap there, but it mostly hibernating, as you can see. So the reason of this case is not really wire escalation; it's really
good.
therapy. So now we cross. So we're going to do an
Make life
IVUS.
easy.
Yeah, absolutely. So as we all know, the concept of vessel prep, the concept of what we do. I mean, how do you guys decide? I mean, we all know that the vessel needs to be prepped. I mean, I think it's not part of our guidelines, but I think it's part of our accepted practice and a norm. So the idea would be is, we have vessel prep to prep the vessel for destination therapy. So in this case, I'm going to do an IVUS because I think with imaging, it helps us to at least realize what our vessel prep should be and what it should be, fluorocarthic for me. And as we go, low mag ray, as we go, I want you to just let me know,
I think,
little higher again?
yeah, I think that's a very good point because eventually the vessel prep is going to determine the success. I mean, now, thank God, we
Little higher,
have a
guys? There you go.
bioabsorbable scaffold which gives a little bit more long duration and good results, but purely for
Can we
below
go
the knee
live?
lesions, especially for these
Laura,
long
please?
lesions,
Yeah.
we've seen in
It's
our
right there
practice
at the
that
bone,
they
PK.
will come
Right
back
there at the bone,
with
right there. Down
might not be whole CTO,
You wanna
but
put the wire a little
segmental
bit forward?
stenosis versus complete
wire's
occlusion.
okay.
So we want to make sure we do good vessel prep for better wound healing and long-term viability. So I think IVUS will give us a lot of information in this case
calcification.
and help us determine because we have an atherectomy, we have atherotomy, we have lithotripsy.
yeah.
Correct. So multiple options available nowadays for us to treat a vessel and have followed by definitive therapy, whatever you need in this case. So
All right,
yeah,
so-
IVUS definitely helps.
Can you guys see the IVUS?
Yes.
All right, so now you can see the IVUS, and I'm going to start recording. I mean, pulling back slowly.
You still get into the entry point. You want to go down a little?
I'm gonna go down
we're
a
still
little
in
bit
the
more.
CTO segment.
You're still in the
Laura?
CTO segment.
Okay. Can we
Just adjust the image a little bit, I
can
think.
we
Yeah,
adjust
maybe
the image,
increase
guys?
the gain. Yeah, just go adjust image, increase the gain to 55.
Increase the gain to 55, please.
Damien, just go adjust image on the top, on the right-hand side on the top.
Yeah. Well, too much.
We don't have a
IVUS
screen
is
here.
frozen.
There.
I got it.
Thanks, Carl. Yeah. The other 55. 60 is good. Perfect. Okay, that's good.
All
Okay,
right, record.
go for it. Ring down.
All right, guys. So we're going to ring down and we're recording.
Record.
Okay,
Yeah.
here we go. So I'm curious
Roomba.
how everybody's going to interpret this IVUS. So you can see here.
Calcium, not that bad.
There are areas where there is 360 calcium.
Right there. Yeah.
Right there.
Eccentric calcium right there. Yeah.
Right there. That's
Right there
360
again.
calcium. More like a medial calcification.
Yeah. But I think that's what highlights the idea of using intravascular ultrasound, that how much we sometimes underestimate calcification, because on X-ray, like me and Raman are talking about, it looks calcified, moderate maybe, but here you can see there's more circumferential at multiple spots, suggestive that there is definitely significant moderate, not completely like tram track, but there is significant calcification, which might need some plaque modification. We can discuss the options to give it a better result than luminal gain. So yeah.
There are reasons. Yeah, still. Yeah, I mean, I think this really does speak to the same point, Vishal. I mean, this is
PXL.
by the original angiogram. We don't really see too much, but this is demonstrating a very, very different story here.
Correct.
Yeah.
All right, guys. So you've seen it. What are the thoughts? I mean, first interpret the IVUS, and then what do you think are our choices for? Or do we need vessel prep? No need vessel prep. What do you think?
Yeah, I mean, I think there's vessel prep has to be included here. You know, you have a long CTO segment, and with IVUS, you see that there's actually by 80% of the entire length of the lesion has near circumferential calcium.
Yeah, more
proximal. So I think as far as the preparation is considered, I think one of the things to consider is what's the role of IVL here versus another form that can also has specific indications for severe calcium, which is the Serenator atherotomy device.
That's a good point.
To think about, you know, your other straight atherectomies, either directional or rotational. I think these are still, or orbital actually. I think you can make a good argument for almost all of these. I would say that as far as the atherectomies are concerned, I would say probably orbital probably has the most suitable atherectomy design out of all of them for a lesion like this. That being said, this was a CTO segment. I mean, at least we have the IVUS to confirm that we've been interluminal the entire time. I would probably, if I had to choose, I would probably choose between the a Serenator or an IVL in this case.
Nice. Raman, Vishal?
So I mean, if you look at the IVUS, the reason you think your wire passed that easy, like you showed, except, I mean, not questioning your technical skills, is you can see on the IVUS, it's not a lot of calcified intraluminal CTO. There's probably a thrombotic component to it, plus a plaque morid. There is definitely medial calcification, which Karthik was talking about. I mean, in this case, I would probably, in my stuff, I would probably do an atherectomy with PTA and maybe Aspirin, the scaffold, bioabsorbable scaffold if needed. Shockwave, you could go yes and nay, because remember, the whole idea of shockwave is breaking the calcification in the wall to have good luminal gain. But if you look here, the lumen is still present. It's decent enough. So if I do a regular PTA with your orbital atherectomy, I guess is one of the options, I think we should get decent results without having to use shockwave in this case. If there are still segments left after my stuff, then I would probably go for shockwave as my bailout strategy to get my luminal gain. But if you look at the IVUS completely, there is definite lumen there, and except for one segment proximally where there is definitely narrowing of lumen. So for my case, I'll do an atherectomy with PTA and as a shockwave, or IVL as a bailout, and then followed by a bioabsorbable scaffold as needed.
Karthik, anything?
Orbital, I think, is a good option. Long diffuse segment. I agree with Raman.
I actually agree with Vishal on this. I think it's all medial calcification. I think it's all atherosclerotic. The way the wire went through, I think it's all atherosclerotic. Mainly, I would use a directional atherectomy here. And then
this is great. I mean, look at this. So I presented this case just because, look, I mean, the idea when Karthik found this case and we talked about it, we knew technically is not one of the hardest cases we've ever done. It's definitely not by any means, but same time, I think that the decision is the idea. And you can see here, everybody has wonderful logic to the audience back home. I mean, you see that Raman's wonderful idea about looking at the calcium, making the decision based on luminal gain, vessel prep, Vishal talking about the lumen already present, and Karthik talking about medial calcification all makes sense. But the idea now I want to revert to you guys a little bit more is, why don't we base it on the destination therapy? Because now, for the first time, we have destination therapy below knee. Because in the past, as you know, Raman and Vishal, we would do both atherectomy followed by just balloon and leave it alone. Oh, it looks good. Or maybe a DS, which is off-label. But now we have an indicated product. So if you're saying that, now, first of all, do you believe that Aspirin is the destination therapy below knee? Or do you think that we can still get away with just atherectomy balloon at this stage, or vessel prep balloon? Let me not say atherectomy balloon, vessel prep balloon. Karthik?
So I feel like, I mean, most of the lumen we were able to cross easily. I think the biggest issue we had was to cross that proximal point where there was a cap, proximal
Ray, can you
cap.
play the film?
The distal cap was not a problem to cross, right? The
Mm-hmm.
proximal cap was this. I think atherectomizing, ballooning most of the segment, prepping the segment, if everything is fine, there is no recoil. Of course, there's a recoil, you have to go through an atherotomy like Raman was saying. But I think the proximal segment, we can do an Aspirin as a destination therapy.
But only one Aspirin you would do, or we?
I would just do one Aspirin.
Okay. Interesting.
And then
How
leave
about
it
you
because-
guys?
Well, I mean,
the whole
we
segment
have,
is
we have
occluded,
data.
right?
Yeah, I know, but remember, I mean, the good thing, like you talked about, is we have a bioabsorbable scaffold, and after 2 years, the data is pretty convincing with 48% reduction in reintervention, and that's exactly what we want in this patient, is not only having patency and good blood flow to the wound, but also decrease the reintervention rate in these kinds of people. So, I mean, Aspirin or the bioabsorbable scaffold will be my definitive therapy. The question really arises is 1, 2, 3, 4, and where do we tip the line? That, I think, angiographically will determine, and then we want to make sure what we can leave with possible atherectomy plus minus atherotomy versus no, this segment really needs a scaffold to really sustain its lumen. So that will depend after I do my atherectomy plus PTA, and then determine the amount or the number of scaffolds you want to use.
Excellent points.
Just considering if you do choose to put the resorbable scaffolds
you
on
want
the
to
entire
take
length
that?
of this, you're going to end up putting at least 4.
4 easy, yeah.
Maybe 5.
Not yet.
And I think the idea of doing your plaque
Give
modification
it time.
first, and doing your
assuming
vessel
you
prep
want to do
first, and then see how
PTA and
everything
then
looks.
atherotomy?
I agree.
I think you decide
Let's see
that
how
you're
it
going
decides.
to do an Esprit at least in the beginning.
Correct.
Right?
Yeah,
Right.
Yeah.
I think
Well-
at least in that proximal segment.
Yeah.
Right. And
So it was-
then see what you need for
So I think,
elsewhere.
so the inflow is, I guess, what caused the problem. Then you're right. You use it as the inflow, size it, and hopefully you make sure the blood flow goes.
So we know the lesion length study was about 170 millimeters. It's probably a little longer than that. We know from our Sinai data that's going to come out hopefully soon that as we finish up our ultrasounds, that longer lesions seem to do better with more full lesion coverage. So I think that looking at this, to me, you have an occluded segment, of vessel, albeit you're right, it was underfilled. And I think the era of vessel prep is now the era, in my opinion, the era of optimizing the outcomes of what's really proven to be, in a randomized control fashion better than PTA. So to me, if you look at the modes of Esprit failure that have been described, not in the coronaries, but even in the peripheral, it seems that malapposition is one, 2 is undersizing is the other, and obviously 3 is a fracture from oversizing or overinflation. So we have an IVUS here to tell us the size of the vessel, which I believe is around, what is it, a 3 or 3.5?
Yeah,
Michelle? And so the idea would be is probably vessel prep. I like Raman's idea because I think putting a serenator in, minimizes the cost, allows plaque modification, and allows us to get a maximum luminal gain. And then obviously once we have a good lumen, we can IVUS again, and then decide whether we want to go with the Esprit or maybe do a focal lithotripsy, which I don't think we'll need. If you guys are okay with it, I want to avoid the cost of an atherectomy here because I like we do have a good lumen. I think we'll modify the plaque with a long serenator, maybe a 3.0 long serenator, and then we'll decide with an Esprit. Is that okay with you guys?
Yeah, Raman just lost his. I mean, that's a good idea. Like you said, we have the lumen there. So if you can do an
Give me a
atherotomy
2.5 long balloon, guys, first to
and then
predilate.
go from there. So he wants to do just to update Raman, he wants to do a atherotomy with possible.
Serenator.
Atherotomy. So serenator with possible scaffold.
2.5 long, 200.
He wants to skip
point.
on the atherectomy part. Save on cost, which I think it's a fair proposition.
Yeah.
I think doing atherotomy in this case definitely would give you enough
Almost
lumen gain to
3.54
use the scalpel.
approximately.
So give us a 3.0 long regular balloon.
There's
3.0
so many
long.
variations to how to handle this, but I think taking a step back and considering what you would like to be your destination therapy helps you kind of narrow and kind of funnel your options.
Yeah,
I think
that's a great point, Raman.
It's a good strategy.
Yeah. But Raman, I think for the first time, as you know, I mean, we have this particular device that at least you and I can say. So now let's talk a little bit about cost. I mean, obviously it's a cost prohibitive, but Abbott is coming out with different programs. We are currently participating in a program with Abbott that reduces the cost of multiple Esprits out to $170, which is FDA approved. Obviously, that's each hospital has to work on its own thing with your Abbott rep. But I think that the idea here is, it is very cost prohibitive, and Abbott is very cognizant of allowing us to be able to use allowing us to be able to use this particular device as needed. I can't see the balloon, guys. You got to let me know.
Yeah.
So the idea would be is as I go down here with the 3.0.
There's a regular or a serenator?
Regular.
Regular.
Probably up
It's
there.
not quite there yet. Yep, there it is. Okay, good. Now let's go up.
A little bit more.
Right there. Okay. So this is a 3.0 Raman IVUS size, Vishal, and now we're going to go up. Can you show the balloon inflation better for me, guys? So we're gonna go off the bone if we can. I know this is a very difficult situation with his ulcer. So
The other way.
mag it up a little now. There you go.
No, but
There
you're right.
go.
I mean,
good. Let's
at
go
the end
up.
of the day, you're right. I mean, in order to get good, we have
Mag
to
it
be
up.
cognizant of the economic standpoint. So here, if you use a regular PTA balloon versus 2 sizes of Serenator, now the math starts to change as well, because Serenator, works good if it's sized well, and there's a tapering of the vessel proximally is like 3.5, 3.75 distally if it's a 3.0. Then for an ideal
Expanded well.
atherectomy results, you need 2 different sizes to get a true benefit of using an atherotomy balloon. So versus an atherectomy, like we talked about, do an orbital atherectomy all the way down and do a PT, a tapered balloon PT, and then go from there.
Yeah.
And in our group, I mean, Raman's done a lot of work with the Serenator. Actually, I've learned a lot from him and his technique. And I think the proper use of the balloon, maybe Raman, you can describe it a little bit, because sometimes people are too quick and don't allow it to work.
Yeah.
And take it from there.
Yeah, I mean, so the balloon itself, they tried to not call it a strict atherotomy device. They're trying to get their own verb associated with it, which I think is not terribly incorrect. Because it acts in a little bit of a different way. It has these 3 perforated edges to it.
I will probably go a little bit more down.
The SLR, as the 2.0 balloon, has only 2 perforated edges.
Yep.
They're working on transitioning all of them to have eventually 2 of these perforated edges. But then again, it's very important that you keep in mind what Vishal was talking about, that the sizing of the balloon should be 1-to-1 or close, or very, very close to it. And if you believe the idea that that there is a lot of tapering in the tibial vessels, which some cases you do see, some cases you don't see, by their definitions, they say you must take 2 different sizes. Correct. Now, I've found there are ways around that, and it comes to basically choosing the greater of the 2 sizes for the entire length. And just at the distal edge, at the smaller side, just go distal and go, instead of going 4 and then 6, go 2 and 4. Really be guided, and you really want to give the time, the full 1 minute at each of these atmospheres to really allow the full creation of this longitudinal perforation to allow the actual dissection to occur as intended.
Yeah, so I think I agree with Raman. The fame to game for Serenator is patience. 1 minute at 4 atmosphere, which they consider as the minimal, and then another extra minute for 6 by the clock. So if you do it by that, I think we've both seen excellent results. It looks as if we have
put a stent in.
Exactly. You would not be able to tell. So I think I agree with Raman. It's just the sizing is the most important, and we've learned everywhere. So let's see what after regular PTA.
So this is just regular PTA. There's your AT filling beautifully.
Wow.
Yeah. So now,
good.
Now it's going to be a good argument about whether we're going to scaffold the whole thing, because it looks gorgeous. Let's take a. But again, we know this doesn't work, Raman. We know this doesn't work.
Yeah. The PTA.
I mean, how many times?
30,
how many times we've seen? How many times we've seen a beautiful result and we come back in 6 months?
Yeah, you're right. You're right. I think I agree.
So look at the foot now. So now we're going to go with the Serenator. Give me Raman said size up a little bit. So let's go with a 3.5.
No, but are you
for which segment? For
exactly. That's what I was going to ask. Where are you planning to put your 3.5?
Well, we wanted to do the whole thing, so why don't you just do a 3.0?
So remember, the whole idea, I'm sure everybody knows in the audience, is for using a scaffold. No, you were one of the primary investigators in the trial, so I don't know what to tell you. It's like preaching to the choir. But we cannot put a scaffold in the last 10 centimeters above the ankle. So we have to be cognizant of the fact that we don't dissect the part or the outflow, and now we're not able to put a scaffold. The rest, like PK said, if you want to scaffold, forget the economic part of it. We can scaffold all the way up to the origin, but we have to preserve the outflow in this case where Karthik had balloons. So I would not go aggressive on the 3.5.
If you go mid-foot, 3.5, all the way up.
Yeah.
And that's
so Raman, question. When you size the Serenator, right? So if you go 3.5, when you go up to nominal, it is a 3.5
Yes.
inflation. Okay,
Yeah.
okay.
Yeah.
Okay.
But if you go greater, you gain like maybe like a quarter of a
Correct.
Okay, so nominal is 3.5. So even if the okay, I see.
I mean, the problem is you should go nominal.
They're all low pressure inflations.
Right,
correct.
Like this balloon is not designed to really need to go to high pressure inflations.
You want
Got
the
it.
longitudinal serrations to open up. So if you don't really inflate it, it's not going to really do an even cut like the stent light effect you really get.
Okay.
Actually comes
I
when you
can't
size
see.
it and do it the nominal size.
For some reason.
So in this case, I
for
probably
it.
might do a 3.0 distally and then do whatever scaffold if you have to proximally and then go for
I
it.
mean, distally looks good enough. I wouldn't even touch it. I think just focus on the
Proximal?
proximal mid.
That's
do
fair.
a 3.5.
No, the entry point was a very.
So
if you look
so
at
what
it,
is the length here, Damien, of this balloon? 80. So they don't make longer ones, or they do?
No, they do.
Yeah, well,
120.
120.
Oh, okay. So at least we have an 80, so we can do an 80.
So this is what I
we
don't
can
like
come
is
back.
that area right at the
we
end.
can come back. We can come back here.
So there, if you do a certain
no,
area,
that's
it'll
good.
be
That's
very
good. That's good.
Right.
Okay, there's a small D there. That's we wanted there.
Yeah. Okay. So this is where do you go now? We go up to 4.
Or
For
for
30
minute.
Leave it for a minute.
And this is a 3.5.
This is a 3.0.
Yeah.
And we may take a 3.5 proximally. Again, I don't think we might need to because it expanded
Yeah.
really well.
Yeah.
Exactly.
We'll-
That's what I was
we'll-
going
I
to say.
think
Yeah.
since it did expand so well, you could also just take this and go to 6 and 8
Yeah.
instead proximally to get a little bit more. Because the idea of what they say with this device is that if you're in a CTO segment, and even if you go with a small serenator, once you create these perforations, every subsequent
two
dilation
3.5
that's being
scaffolds and
performed
2 3
will
7.5
dissect
scaffolds.
along this perforation.
38.
Correct.
So if you were to, even if you were to go with a 3.0, as long as you're making contact with the wall and you are getting the perforation to be formed, every subsequent inflation
Correct.
will
Why line it?
call the
But it'll heal.
dissection
Yeah.
along that.
So it's pretty much
100%.
having like a controlled dissection rather than PTO, which gives us random
plus we,
dissections. It
we
gives
have
you a
a
controlled
sliding
night
scale.
dissection
So we
along
use
the
5
way, so causing
scaffolds.
the
We pay $1,000
non-flow
scaffold.
limiting stuff. So that's why it has
That's
very
nice.
good results. You're right. So I think that's where important is. So you could probably do it proximally and then put in the scaffold Esprit proximally and have a good outcome.
So 1 minute, now we go to 6?
Yeah, 6. Is-
Do we come down and go up, or do we just go
No,
up?
no,
Just go up.
Right to
Just
6.
like shockwave.
No, it's important because a lot of people have a lot of doubts on the technical aspects of inflating this device.
Yeah.
Not yet.
It takes patience. It takes patience. There's no question
It's
about
like doing
it.
And how long do you leave it up, and the second time you go up?
Another 60 seconds.
Wow, so a lot of
Yeah.
patience. Okay.
Yeah. That's why honestly I try my hardest to be able to use the longest the longest lengths available, like the 120s. There are times where unfortunately you just don't
It
have.
doesn't deliver.
Yeah.
Also, sometimes it
Yeah.
can give you that stuff. It's very calcified. But you're right. 120 gives you a longer length. But I think we should be good. In this case, the length should suffice, and proximally you can put it on a scaffold.
Yeah.
Down.
And what's the plan that you have for the eventual?
I was
Esprit
gonna IVUS Raman now post this and then decide together on I really believe that we need to fully scaffold the whole thing. Karthik just asked me, are we really going to use that many scaffolds, which I know it sounds like a lot of money, and it is, but the point is that I think with the outcomes, especially with our own data now, which we're going to get out soon as Vishal gives us the ultrasounds, is basically showing that the longer lesions do a lot actually do fantastic, while when you do spot scaffolding in these CTOs and other therapies for distal, it's actually showing a worse outcome with the balloon, with the scaffold. So therefore, I think sirolimus may change that. As you know, we're part of the Magical BTK. We're part of all different trials, luckily at Sinai, and hopefully that will change that. But right now, the only thing we have is one thing Dr. Guja could do is say, hey, listen, I'm going to survey this guy, put a scaffold in the worst area, and then I'll follow him. But that's going to lead to higher reinterventions, which may be avoided, because one thing, as Vishal went over, was reduction in TLR rates, higher patency rates, and obviously a higher rate of amputation-free survival in this particular vessel, in this particular type of lesion. The other part also, Raman and Vishal, as you know, is that the wound is very small.
Yeah.
So because the wound is very small, if we can give him 3 to 6 months of patency, it's going to heal. So the argument could be, hey, with a balloon angioplasty and a serenator and maybe a focal scaffold, I can give this gentleman gentleman 3 to 6 months of patency, and then heal this wound, and then go ahead and follow him. So it becomes philosophical. It's part of the reason why we're presenting all this.
Yeah, so I think that's a very good point. Is depending on what's the stage or presentation of a patient. If it was just purely Rutherford Grade 4, which is CLI, then I agree with you. I might not be as aggressive in Esprit, where you can, if everything done rightly, angiographically, hopefully surveillance should be fine and do okay. Versus the patient who's already had an active wound or gangrene or all the stuff. In those cases, you would want to get more aggressive to have a longer patency rate. So in this case, you're right. Following up just based on PTA and atherectomy, the data we know is not good. So I would probably be more aggressive and go upfront scaffolding as my final definitive therapy. And now the question really arises: how many that we can discuss, argue, or review, whatever you want to call it.
Yeah. I mean, I think this is kind of highlighting the paradigm shift in tibial interventions in general.
Right.
Before, the idea was do tibial interventions so a wound can heal, do it so that the resting pain can improve, or it's just, and it's like with the adage, it's an adage to the fact that we want to just get this temporary fix, accepting that it is going to fail. With the Esprit stents, it's a little bit of a different story. I mean, you have great data for patency at the 2 years. You're not talking about wound healing anymore. You're talking about a definite therapy that has an extended period of patency. So I think, if the idea was, look, like let's just get this guy who's super high risk, who's still smoking, has CKD and this and that, blah blah. We just want his wound to heal, and that's it. Then the question is, as you were saying, do you just do atherectomy, PTA, maybe just a coronary stent in the most serious areas, which also still has very good data, right?
I mean, absolutely.
And save the Esprits entirely, But again, I think all things considered, there must be a paradigm shift. We have to eventually leave the thinking that tibial interventions are just for a temporary fix to allow for wound healing. At the end of the day, we need complete, definitive, long-term therapy.
I agree. I think the outlook has been changing, and we have to change to treat it as a final definitive therapy rather than a bridging gap to something which doesn't exist, or maybe a bypass. So So in this case, I mean, I guess Speaker and Karthik are going to talk about how sizing is important, and especially in we have an IVUS to give us a true use of what size of Esprit you want to use in these patients, and some patients have more bigger vessels than 4 or 5. Like, we talk about how big the Esprit can go to its nominal size. In those cases, like Raman said, we have the option of using even a drug-eluting stent, which again has great data. So we could do a combination therapy in case the size doesn't fit our build. So yes.
So we're going up to the ostium because there's disease up to the ostium.
Yes, and now segment proximity, correct.
Yeah, now we're going the way Raman said, to go up to 8 atmospheres after a minute. And then we're going to IVUS. And the idea is there's been no data on hybrid therapy. We do have, obviously, I think we have a good number of cases now with hybrid therapy with Esprit and with DES, with an off-label DES, especially in vessels that were larger than the Esprit, IFU. So therefore, it's that's also interesting that we're going to get out of here very soon. But I really believe that at this stage, with the IVUS is going to help us make a difference. Then I guess our judgment as a group will help. The second question I want to ask Karthik. So I think more and more with STEMI, as we know with all cardiologists, that multivessel PCI and the global revascularization seems to be the thing. Now there's some data coming out of Europe that shows that multiple interventions of multiple vessels below the knee also expedite and sustain wound healing. So there's a nice paper out of Italy, out of Manzi's group, that shows that multivessel tibial angioplasty, it works better. So right now we have a focal perineal artery, both proximal and distal. So would you open that while you're here, or would you just open the AT because of the wound size and leave them alone?
Yeah, I'm a strong believer of doing multi-vessel intervention, especially when it comes to CLI.
IVUS?
My approach to this would be totally different from all three of you guys, actually. So I would not. I would not put any. So because I see wound healing as a primary reason for tibial intervention. I know there is a paradigm shift, but the wound is not that big. So I would use an Esprit only in the proximal AT here, because I think we got a very good result with atherectomy and PTA.
I got it.
So I would use the second Aspirin in peroneal, which might actually help him over time because it's a focal lesion. Peroneal will stay patent. I think his resting pain might actually benefit more from the peroneal patency than from the AT patency. I think we are getting better at tibial interventions, but I don't think a couple of Aspirins are going to prevent this AT from shutting down after a year or 2 years.
Except but there is data to support that.
Yeah.
Yes,
right?
yes, there is
data
absolutely
to show that at 2 years there is
absolutely. So I feel like giving him probably the peroneal patency is also as important as AT.
IVUS, guys?
Yeah.
So
Well, I mean,
that's what I would have done.
No, we haven't finished yet.
Yeah.
At the end of the day, it's your patient.
But I agree with PK and you guys 100%.
I agree. The peroneal is a chip shot, and I think the added benefit to fixing that at the time of this, less the cost of actually trying to fix it, will greatly be in favor for the longevity of whatever treatment we decide today. I think adding the extra vessel that is clearly giving collaterals to the distal AT, which no longer are going to be significant, but to the little remnants of the PT. Right. I think for sure fixing the peroneal should be on today's agenda. I don't. Do you agree?
Yeah, no, I agree. I mean, if you look at the initial shots, it was because of the peroneal is why the wound is not as big as what it is.
Yeah.
I remember we always treat, like the old school people would tell you, peroneal is like a profunda. It survives. Mm-hmm. Make sure the leg survives and you don't have much amputation based on it. So we definitely should treat the peroneal as well, just in case the AT doesn't do its job, which is supposed to do, and the peroneal is what's going to save the wound from getting worse.
Where are you right now?
So we are almost in mid to distal.
There's the IVUS right there, Raman.
Yeah, okay, there's the catheter. Well, still, I mean, there's
still a lot of plaque burden.
Distal, yeah. I mean, you could have taken the atherectomy even lower.
Yeah, that's what I thought.
So PK started almost in the dorsalis pedis. Even in dorsalis pedis, there's a lot of plaque.
Yeah, but you can't. I think right now that's a patent vessel.
Yeah, I agree. With PK.
I think right now the question is, what do you guys think about the result with atherectomy? I'm so impressed.
Yeah.
Yeah, but it could be deceptive, like we talked about.
Yeah.
I don't know. I mean, that's my concern is.
But I don't see much recoil anywhere except that area. Except that area where the proximal.
Right yeah.
Except that area, I don't see any much recoil anywhere, Vishal.
Okay, so
I agree. I would probably put I would go for the proximal Aspirin.
All right, give me two 375 38s.
And come to the level of the ostium and just stent the ostium in the proximal portion.
If you can actually go to the proximal segment of the IVUS, you can actually see something pretty neat. You can actually see the little fraction, the little fracture happening in the calcium.
Can you speed up the IVUS, Ray, to the proximal segment?
Proximal segment.
I think I raised
it. You still see some fractures as well as you go, especially at 11, between 11 and 12.
But there was much more dense calcium closer.
Correct.
And you can see that there's a very clear fracture.
Good.
A little more. Or maybe my eyes are just making it up. Who knows?
The Ray is moving it for you, so.
Yeah, right there.
Right there.
You see that? Yeah, right at like 2 o'clock.
That's right to the level of the ostium, Raman. That's exactly where your ostium starts.
I think we should treat, maybe put a couple of scaffolds up proximally, and that should probably be enough for us to...
So you say you're doing 375s?
Yeah.
Yeah, brother. I'm going to use 375, but Raman, I think what I'm going to do is I'm going to go proximal to distal because I'm antegrade. I want to hit the ostium for sure. Normally we'd go distal to proximal. I don't think I'll have a problem tracking this because of the antegrade sheath. So I'm going to go proximal to distal here just to hit the ostium and then go down. Normally, if I was up and over, I'd probably go distal to proximal because I think that I definitely I agree with you guys. I think the results are Maggot up, guys. I think the results are great. And I think if we can get full lesion coverage proximally, I think we'll be good with that outflow. Here we go. Little die here, guys. So again, we're going to mag it up. As you guys can see back home, you cannot see the vessel at all or the device at all. So because of that, you really want to see the tantalum markers. Can you mag it up, the night node markers? Yeah. So the night node markers are where the stent ends, and I'm going to do a dry cine ray. Dry cine ray? Okay. No, that's not a dry cine ray.
We're giving it.
So we're going to give you a dry cine here. and you're going to see the markers, and the markers are going to be where the scaffold starts and stops. So do you see it now next to the balloon dots? Not really.
Yeah.
Okay.
It's faintly.
Yeah, little die, guys. So there you go. I want to make sure we're hitting the ostium here. I think I'm pretty good. All right, let's go. Let's go up a little bit here slowly. So we go up. One atmosphere. Karthik, can you talk about going up?
So we usually go 2 atmospheres and wait for 30 seconds.
5 seconds. 5 seconds. 30 seconds.
30 seconds in total, like total 30
no, 5
seconds.
seconds, then go up
5
again,
seconds and
another,
then go up 2 more.
Go up
to
again.
9.
And nominal is 9.
So you count 1, 2, 3, 4, 5. Yeah.
Go up again.
This
30
case
seconds
is
in
an
total.
exercise in patience.
Well, it's funny because for the first time we've actually have results that are very, very, obviously impressive with these scaffolds, which I think are really, really helpful. So, what are we at now?
We are at 8.
8
And 9.
And
then 9. And I'm going to leave it up for 30 seconds, as Karthik wants to do. So once we leave it up for 30 seconds, we're going to go up and go. We have to post-dilate these. So Damien, give me a 40 balloon. Because you can take it up to 0.5 of your nominal.
Yes.
So okay, 30 seconds are up, down, and go up again to 9. So we're just going to go up. Give me another scaffold, Ray. Another 375. Okay, good. Down. Okay, now I'm going to go ahead and put the other scaffold in, and then we'll do the perineal. So how do you guys want to do a similar treatment of the perineal? Serenator followed by?
I would just balloon it and stand it.
Perineal offline. Atherotomy with Aspirin.
Okay, makes sense. I agree with you because almost 9 o'clock, but I think we can do it. We always do it on time. But let's see here. So as far as closure, guys, what do you guys? Let's talk a little about.
Oh, yeah,
I'm sure a lot of people are wondering how they're dealing with this. I told you we're going to vascate the supera access because it's a 4 French. It should be no big deal to control that. How are you going to deal with the antegrade stick?
Vascated.
No, Karthik wants to vascate it. Yeah, I'm not going to vascate it. No way.
Yeah.
I'll hold pressure.
The answer in our lab as of right now, based off our equipment, would be to use your fingers. But I think that down in the OR they have the new device Kelt, which is quite good for this. You do sacrifice a 2 millimeter spec of access point in the future, but I still think that's a reasonable loss.
So you can see how nicely it tracks. And now I'm going to line up. Can you mag it up to 48, guys?
Yeah. So P, can you talk about the overlap? How much we have to, and what's the?
Yeah. So you see the markers there, guys. I lined up all the markers on top of one another. You see that? Yeah. So now it's a perfect place to go up. Now go up, guys. So it's just inside the other stent, or actually they are butting each other. And now we're going to go up at this stage. So go up again. So now the markers are covering. They're not on top of one another. They are butting one another, which is perfect. So now we got it. Now Karthik is going to go up, and I always post dilate these because in the clinical trial we post dilated all the stents, all the scaffolds up to another 0.5 up to 0.5.
Yeah, definitely.
So I think it's important. Again, we know the reason these fail. And I'm going to IVUS it quickly before we have 5 minutes before we go offline, and we'll do the other stuff offline. But I just want to show you the result here with IVUS, and then we'll take a couple of final pictures, and then Karthik and I'll do the other stuff offline. How does it look? 30 seconds.
Beautiful.
Okay. So antiplatelet therapy, does it change in any way for you guys now with the new rivaroxaban? Obviously, it hasn't been studied with this particular device. Are you changing your therapy in this particular subset?
It's a 1-year dual antiplatelet per the recommendation, so that's one thing you always have to consider.
But he's already taking aspirin Brilinta, right?
Yeah. So I'm going to leave him on aspirin Brilinta.
Yeah. Okay, down. So Karthik, are you going to add Xarelto to this?
No, I'm just going to keep him on aspirin Brilinta. He has done very well with Brilinta, so.
Okay.
I mean, his
4 balloon guys, and then IVUS, and then we'll be done. 4030 is fine. So we're going to post-dilate, get the maximal luminal gain here, and then we'll do a quick IVUS.
Beautiful. How long ago was the left main PCI?
2003.
Oh, 2000? Huh?
2003. 2023. Sorry, 2023.
Yeah.
That's what I mean.
Jesus.
2023.
Well, then technically, based off of that, you can do whatever,
Yeah.
right?
Yeah.
I don't know, because he's probably such a high risk with complex interventions.
You had him on 90 or 60, Berlin?
Probably switched to
90.
60 now.
90 twice
still.
a day. Yeah. He's tolerated it, and we did a supera. We did a supera about a year ago, so I just left him on Berlin of 190 twice a day.
Well, I mean, listen, you have data to show that
60.
that 60 is a
60
long-term
is long-term.
After one
long-term Berlin
Yeah.
usage. But that being said, I mean, it now is just a balancing act, really. Like, if he's revascularized from a cardiovascular perspective, and his EF has improved, and he's not having any cardiovascular symptoms, but he is having lower extremity symptoms with CLI. Should there be a temporary paradigm shift or a treatment shift towards focusing on the best medical therapy post-intervention? Now, obviously, with the Aspirin, they kind of complicated, saying you can only use aspirin Plavix.
Yeah. Correct. And that too for a year. So back to the cycle restarts. Yeah. That's the issue. So
I do find that a little restrictive. I'm not gonna lie. It's pretty restrictive.
I agree.
Go up to 6. So we're just post-dilating everything, and then we're going to go up and just go ahead and take a quick IVUS down. All right, IVUS, guys.
Do you ever had any patients some Xarelto on top of their aspirin Plavix after an Aspirin, or you keep them by the book, as they ask?
No, I do. I mean, younger patients who I suspect the bleeding risk on the lower side, I try to use the Xarelto 2.5 to see how they respond. And if they tolerate it well, like you said, with no recent any colonoscopy, EGD, all the stuff coming in, I usually can try it. If they do fine, I'll keep them on it. But it all, again, patient dependent, based on patient characteristics, history. I try to tailor it, but again, ideally I would want them to be on rivaroxaban, to be honest. But triple therapy just
it has its own risks.
Correct, exactly. So
we're just gonna IVUS now. So IVUS going in, and then we'll take a final.
I almost don't put. Ooh, easy.
There you go. Okay.
I almost don't put anybody
Ready,
on triple
IVUS?
therapy anymore, Raman. So
I'm just going to pull back. Make sure. I just want to make sure whether we can see the
Stent is
scaffold.
Yeah.
So there's
There
the
it is,
scaffold.
the
There it is. You see it. The scaffold is beautiful. Well expanded, circular, no indentation, very elliptical there, but that's fine. A little bit of indentation there, but well opposed. And then you can see here.
That's good. That was the overlap.
I think it looks pretty good. So we're done with that. Now we're just going to take a couple of pictures. Ready, Karthik? DSA. And then we'll do it offline. Oh.
Yeah, we didn't.
Sorry.
Yeah.
Karthik wasn't ready there.
Floor.
Karthik did not generate enough PSI.
All right.
No, it's not PSI. I didn't zoom out.
So here's the Aspirin arm there. Beautiful.
Looks nice.
Very nice.
Yeah, the patient's going to do very well by fixing that perineal too.
We're going to fix the
Two is better
perineal
than one.
offline
In
here.
this case, for sure, yes.
So go ahead, DSA.
The good thing is the arch completely fills up, so you're going to see everything just lighten up, hopefully, after this intervention. So
after the perineal's done, then you'll see room for the PT to be opened up.
There's the PT right there. You see it? Right there. All right. So with that, I guess, it was a great case, guys. Great discussion. I think what we'll do, Karthik and I will do, is offline here, go ahead and fix the perineal. And I think if there are any other comments or anything that you guys would do different here, Flora, Karthik?
No, everything I think was a good discussion about various, like you said, vessel prep is the topic of discussion for today. It's not about how to cross, but how to, once you cross, how to deal with it and what options we have. And I think Raman, me, and everybody else here had a nice discussion about all the modalities that are present for us to use. It's just picking and choosing depending on how the lesion characteristics, some data, and of course personal experience right there. So I don't think that anybody's wrong. We just at the end of the day, the patient has to benefit. So I think this is the best therapy in this case.
So I'm curious, just to conclude, just your thoughts. What data would you guys need to say which vessel prep you would use? Do you need patency data, head-to-head data? What do you guys need, or just safety data?
I think patency data is the most important, right?
Patency and then
at least for tibials now we need patency.
It would be nice to have a head-to-head, but who's going to pay? Who's going to pay that?
Yeah.
Exactly.
I remember even if it's
patency data is probably the most important.
It's probably a true CTO PK.
A little die.
Patency data
Mag it up, right?
Revascularization is, I think, that what would drive in these cases specifically.
And ideally, which two devices would you like to see go head to head? Little die, guys.
I would ideally try to see atherectomy PTA versus stenting.
Okay, looks like a true CTO here.
Yeah.
All right, give me a support catheter, guys.
Yeah, we have it.
Okay, give me a teleport. All right. So with that, Vishal, why don't you sign off, and then we'll see you guys soon.
All right, guys. Well, thank you very much for joining us today. We're glad to have such a great educational discussion on a case that had many different options. And I'm glad to hear everyone's different perspectives and their reasoning as far as why they would choose one over the other. And that being said, we look forward to seeing you again next month on June 25th, the final Wednesday of the month, right before we head into the summer break. So from Mount Sinai Fusa Heart Hospital, thank you very much for joining us today, and have a great day.
Thank you.